Yep.
Oh wow,
There is
thank
a way.
you.
So not a problem. Um, great. So I think what I wanted to start out with is first, I got some feedback from Roger about some ideas on optimization, and I was going to pull up that email, and then also Nish to talk with you as well. And really, what we want to do is first start with the stories. I call them stories or use cases. In an ideal world, if we in a med reconciliation context, what do we think we need and why? Okay, and really starting with that, because then we're going to drill down from these ideals to what's actually doable, right? So, oops, I think Nisha
Yeah.
is
No,
there.
no,
Yeah,
you're
there
fine.
we go. I heard a scream. I hope it wasn't you.
No, it wasn't. It was a little kid.
Okay. Oh,
Sorry,
okay.
sorry for the noise.
No, no problem.
Let me know if it
Um,
gets too loud. I can try to find another spot.
and I think I'm fine with it if you guys are fine. I'm okay. Yeah. So I'm used to little kids screaming. So
um, what I was
yeah.
telling Roger is I was kind of looking off of his email and then trying to expand on it.
Mhm.
Um, and I mean, in terms of the med adherence that he would went over, obviously having the medication name, trying to have like an idea of what maybe the indication would be, and then the class, and
Mhm.
then in terms of
And
like
when
the
you say
actual
class,
adherence,
yeah, can you give me an
um,
example of what you mean by class? Like
like the
antihypertensives, HMG
yeah,
co-reductase
like
inhibitors, things like that. Yeah.
exactly, yeah, like an
Mhm.
ACE or an ARB or
Uh huh.
and I mean, I guess I wouldn't be as ideal to have like necessarily like on a front page of a MedRec system, but like
Mhm.
somehow to get to that, because I mean I don't think that's all that necessary for a nurse or a farm tech or something to see that initially.
Mhm.
But it would definitely help a physician or a pharmacist later on if they had questions about what the indication or what the class was.
Mhm.
um, and then there was the adherence percentage and coloring to show the number of pills taken, and then I also thought that maybe there was a way to also add in like when the last pickup date was from the pharmacy, um,
Mhm.
and so like maybe go into the claims data and be able to just quickly be able to see that this person is like regularly taking it, or at least like right now they have medications at home or not.
Mhm.
And that would help, even on discharges and things like that when you have to, instead of asking the patient if they have meds at home, you could sometimes just reference this instead.
Okay.
Um, and then what other things? As for like just when going over like maybe having a list of like what meds were discontinued, and either like categorize them whether like the patient DC'd them by themselves, if it was a healthcare provider, and then maybe reasons why, maybe a
Mhm.
short just like side effects, and then or non-efficacious or something along those lines.
Mhm.
um just a quick blurb about it. And then one of the other things I was thinking of is like if it is a side effect like from a medication, let's say like they are on an ACE and they develop a cough, maybe having the system listed in the allergy profile, maybe not as
Mhm.
an allergy, but have like a subgroup of like medications that they've like tried and failed kind of thing.
Okay. Great.
Um, and then um, other things that I came up with was just like whether like a program could identify interactions within a med list that was pulled.
Mhm.
Um, instead of a pharmacist having to go through and, necessarily think about, oh, do any of these drugs interact, or having to plug it into like Lexicomp or something, maybe at least major interactions.
Mhm.
It could pull that out from now. Also, cross referencing that list with allergies. I know. I think like Walgreens and CVS systems, I think, do that, like if they have the allergies inputted. But I'm not sure if hospitals actually hospital medrec programs actually do that. But it'd be a cool thing to include so that again it's like a red alert that they are on something that they might be allergic to.
Mhm.
What else did I have? As for dosing, so I think Roger had included this, like a medication history, like we said, the reason for discontinuing, but also like if there's a change in dose, um, or a
Mhm.
change in formulation, if there was a change, like even within the same class, let's say they switched between two of the ACEs or two of the ARBs or something like that,
Mhm.
and then maybe I don't know if we'd be able to, but somehow pull out why those changes were made or why the increase or why the decrease and things like that. In an ideal
Mhm.
world, that'd be great. But
Yep. Yep.
um,
These are all great
what
ideas. That's terrific. And one so there's kind of um, there's a structure. I think we can start to structure this in a way that can break these up into categories that make it easier to understand why. So we want to we've listed some you've mentioned some very good things here, Roger and and Nishta, and these are great. These are actually right on target. The next, but I think the next thing that's really going to be valuable then is to take that list and start thinking in terms of um, what categorizing them as to what do I really need of these features in a workflow and how. Imagine that whatever we say we need, we should think about how we're going to use it. Okay, so how is it going to be used in a workflow for med reconciliation, and maybe build a category that's med reconciliation versus med management. Okay, managing an existing list versus reconciling multiple lists. Okay, so they're different. They sound similar, but they're kind of the reason we want to break them up into categories like that is that when it comes time to really start to define med reconciliation workflows and what kind of computer assisted value are we going to get when we're talking about the workflows, it's very good to have a very clear understanding of what the different workflows are. So let me give you an example. Okay, so I'm just going to start a little diagram here or a little document to make it easier.
Am am I supposed to be able
Mhm.
to? Am I seeing what you're seeing? Or my
Well, yeah.
my
Did you join the meeting? Let me just check here, see if you guys are on the join me.
I don't know if
Um,
I'm broadcasting or if I. Let's see. I'm not on the right thing.
Participants. I have on here. Oh, I see. You guys called in, but you're not on the. You didn't join in. So let me send you the URL. Okay, for joining in. I think that might be what's missing. See if you have it in here. Oh, I see. I didn't send you the URL. That's why. Okay. So let me. I'm emailing that to you right now. Okay. So it's http join.me/psmi consulting. And you should have that in your email in just a second. Okay. But if you just go to your browser and just type in join.me and then /PSMI consulting, all one word, it'll ask you to knock to join, and I'll let you in, and you should see my screen. It might have to download a little plugin to that you'll have to open, but it'll allow me to share my screen with you.
See.
And you should have the email from me now. Yeah.
Yeah, I think I. Let's see. I just put on added to join me. Wait. Oh, I have to. Name must be 9 characters. Oh.
Typically, what it'll do when you put that URL in your web browser, it's gonna ask you to download a little plugin for your browser because you've probably never used Join Me before. So it looks like Nishta made it in, and so Nishta, you can see my screen now. And so what you'll do is you'll put it in, Roger, on their browser,
Okay.
and then once you're in there, if you, there you go, you got it.
Got
Now
it.
you can see my screen. Okay. Yep.
Okay.
So so it's kind of nice. We can just share screens that way, and this link will always be the same. It'll never change, so we can always use it. So basically, if we think about workflows, okay, there are different workflows, right? Okay, so we'll start at a higher level and see and figure out where these things fit. Okay, where these features fit. Okay, so workflows. So if we look at the workflows, let's just do this. Here we go. Get rid of my little draw. Okay, and we'll okay, so if we look at the types of workflows, so one workflow is basically med reconciliation. Okay, and so we define that as basically a comparison of multiple lists. Okay, to against each other. Okay, to identify multiple lists of medications to identify current meds, okay, for current meds for the patient. Okay, so that's one workflow. Okay, so that if you think about it, this is where a pharmacist, a physician, or a nurse, is in a clinic. Okay, and they're thinking, I have a list of meds that came from Walgreens. I have a bag of drugs that the patient just gave me. I have the Epic EMR's list of what the physician thinks the patient's taking. And I want to just look at those three lists and figure out what is the patient really taking. So I'm going to piece together a list of potentially what the patient's taking by looking at those three sources, writing them down or putting them down on a piece of paper, and then looking to see if the patient's on captopril, 12.5 milligrams 3 times a day. It says on their bottle, but on the physician order it says 25 milligrams 3 times a day, and in the pharmacy it says it's 50 milligrams 3 times a day. I have 3 different doses. I have one captopril, drug, 3 different doses. Which one is the patient really on? Then I might actually look at the date and see which one was the most recent. Maybe the other 2 were older doses, and the most recent one is a 50 milligrams a day, and that's the most likely active. So I'm going to try to compose a picture of what active meds a patient's on, right? So the med reconciliation is all about having multiple sources that can possibly conflict with each other, and you want to actually go through the process of trying to identify what are they actually on. Okay, so that's the first workflow, the first context. So within that context, then my question is, what do I need as far as features from the list that we were talking about earlier? So we were talking about, let's take a look at Roger's list and Nishta's list and pull it out from here. Okay, so if we look at these features, which are great features, what is applicable in that workflow context? Okay, so let's take a look in here. I'll just put it for convenience down in the bottom. I'll just start another Word document so we have it side by side. There you go. And so if we open this one, shrink that, rearrange my screen, and here we go. Okay, so if we look at this and say, within the context of med reconciliation, what of these features is important? Okay, we know we have to do comparisons. So medication adherence by medication name, indication of the class. That's probably important. To know what the medication name is and maybe the class, because when we're aligning meds from different sources side by side, it may be convenient to line them up by class or indication, right? So that we don't have the hydrocortisone cream lined up with with hydrocortisone enema or hydrocortisone oral. Okay, so that we know that they're classified together. Makes it easier to review the meds side by side. Okay, so that this may apply. Okay, number one may apply to that context of use. Okay, so we want to organize a list in that manner. Okay, to think about what's useful in that workflow. On the other hand, do I need so over here? Okay, so on the other hand, do I need to for med reconciliation? So timeline. What I'm not sure what you meant by timeline, Roger, on this one. Blocks off.
I wasn't really descriptive of that. I'm sorry about.
Oh, no problem. Yeah.
I kept that was kind of like a half thought. I kept thinking about like the different ways, because you had mentioned about medication adherence, because I had also initially thought of a timeline, and then you talked about your experience, and then I was like, well, maybe that's not. And
oh, I see what you're saying. Yeah.
And then I was, yeah, go ahead.
Yeah, no, I see what you're saying. I just didn't understand the term, but I think I know what you meant now. It's basically that visual, representation of a timeline to see where there might have been breaks in the continuity of adherence. So
I didn't actually describe it.
Yeah.
That was not.
No problem.
So.
As long as I know what you mean, we'll discuss it. But adherence, timelines, and interruptions. Okay, in adherence. So these are useful for med reconciliation workflow, because not only do you want to line up the meds side by side and see what is the patient actively taking, but also in the med reconciliation process, you want to understand, is the patient actually taking the med? I think they're the doc thinks they're taking it, the pharmacy thinks it dispensed it. Is the patient actually taking it? Okay. And so that's useful for med reconciliation. So that's another attribute. Reporting patient med side effects. Okay, so now we get into some things. Is it really useful? Is it a core? Is it a core feature that's important to know patient reported side effects in the med reconciliation workflow? Maybe it is, maybe it isn't, but we have to think why. Okay. So if my goal in med reconciliation is to first identify what is the patient actually actively taking, med patients or reporting patient side effects may not be necessary in there. It may be a collateral thing that we're interested in, but maybe not a primary thing, because if our goal is to first figure out what are they actively taking, that may be that may be a feature that's needed for another context. Okay, so I might actually hold off for this, or you may say, hey Jim, no, I disagree, because for the med reconciliation process, the patient may tell me or that they're not taking a certain med that they should be taking, and when I ask them further, they tell me it's because I don't tolerate it. It makes me cough. Makes me faint, it gives me headaches, and that's a valid thing, but since my goal in med reconciliation is to identify multiple lists of meds and reconcile them to a single list, what I want to do is break down the categories so that I identify what are the core features I need to accomplish that task. Okay, and then maybe for the task of medication medication management. Okay, current active list, and that also incorporates into it an adherence component. Maybe that's where adherence belongs rather than in med reconciliation. It's really, kind of in that workflow of, now that I think I know what you're taking, what you're actively taking, I'm going to try to figure out, are you adherent? Okay, and maybe part of the adherence piece is also figuring out, um, you know, does a patient have side effects to meds? Because that may be a reason why they're not taking it. Okay, I keep telling you I'm allergic to this med, and you keep ordering it for me, or you keep trying to give it to me. Do you see what I mean? Is that it's kind of helpful to break it down by taking a workflow by context and categorizing these features under these. Yeah.
Yeah, I guess
Makes
I
sense?
didn't really think about the difference between med rec and med management. But
Yeah,
that makes sense though.
Yeah.
it makes
And they really are kind of, different sides of the same coin, so it's not like they're completely different, but I think it's useful to think in terms of what would a person do when they're managing meds. So if if you know a patient is going to come in, later today, that you want to talk to about their meds, the pre-work you're going to do is, first you're going to do some pre-work to reconcile the meds. You're going to say, I don't want to be empty-handed. When they come in, I want to have a list of the meds I'm going to ask them about. So you're probably going to do this med reconciliation piece on your own initially, right? You're going to gather the meds from different sources and try to figure out and whittle down the list to what you think the patient's taking based on what you're seeing from each source. So that's kind of typically what I think of as far as workflow, is that I'm going to prepare to do MedRec by first finding out what I can about what the patient's doing before they come in. Then maybe once they come in the workflow, I will be prepared, right? I'll have a list of medications that I've done some homework on, and now I'm going to see, are they adherent? Are they really taking what I think they're taking? Okay, and then I'll have some additional information regarding why why are they not taking it. Adherence may be partly because of the side effects. It may be that they don't have the money to pay for the copay. It may be that they they didn't understand they're supposed to take it. So then we get into the med management piece, which is the interaction between the pharmacist and the patient, right?
I see.
Yep. And then and so I would think of it in terms of, kind of practically, what would you do? What would you do in a workflow? And then map those attributes that you've identified, which are all actually very important, but map them to where they're important, in the workflow, in the stages of workflow. And the reason we want to do that is that later we'll see that there are different opportunities for electronic systems to help us in each one of these workflows. Okay? And that's where we're going to look at the standards, both for terminology as well as for the workflows. There are standards for how the electronic medical record or a pharmacy system interacts with a user. We're going to look for where there are opportunities to optimize that workflow so that the computer does some of this work for us. Okay, it can't do everything, but it can. One thing a computer can certainly do is it can do all of this. Okay, it can even compute for you predicted adherence. Okay, but we want to first categorize them to understand where they appear in a typical day in a scenario of that workflow. And the other thing that this is useful for is that it helps us justify why we're saying these attributes are important. So let's look at a few more attributes. Okay, so we talked about reported side effects. Okay, that can be useful, and we understand why it's useful here, right? In the med management, is that the patient may you're talking to the patient, you're managing their what you think is their current med list, and that's when the patient starts saying, I don't want to take this. It gives me a cough. I don't like Captopril. Okay, and I've told you 10 times I don't like it. So why do you guys keep trying to put me on it? So that's typically what you'd hear from a patient, right? Okay. But then the attribute of timeline blocks or adherence, that's actually useful because it tells you during the med reconciliation process that, hey, you know what, the patient picks up these drugs from the pharmacy half the time. Okay, I'm going to ask him about this. What about why? It looks like you're not picking it up regularly. The patient may say, I keep forgetting, or I don't like this drug, or I don't have the money for the copay. Or they may challenge you. They may say your records are wrong. I pick it up every day. I mean, I pick it up every month, and I'm perfectly fine. And so then then that actually makes the data questionable. Is the pharmacy data accurate? Or is the patient right? Which one is correct? And so it gives us it's a way to check, because if the patient says I'm always taking it and the pharmacy data is wrong, pharmacy dispense data is wrong, then you might say, well, I'm going to do a little more homework with this. I'm going to find out from the pharmacy if the patient's been regularly picking it up by calling them. Okay, and if the pharmacy says nope, half the time she never picks it up, then I can challenge a patient and say, well, I checked with pharmacy. They say that you only picked it up 3 times. You may find out from the patient then that, well, I do pick it up. I just didn't realize I wasn't picking it up regularly. And then you can give them counseling. But think about the workflow, okay, as to how you'd be using those. But then now if we get to like complete medication history, reason for discontinue, dose change in medication, that's useful for what? Okay, is that useful for medication reconciliation, or is it useful for med management? Okay, why do I need to know the reason for discontinuation or dose change, in a medication? So one reason that you might want to know the reason for discontinuation is that you don't want to restart the patient or encourage them to take a drug if there's a good reason why they came off the drug, right? Okay. So that kind of falls into the med management piece, is that you're assessing it here. Okay. Why would you want to use it? Is there a reason why you'd want to use that feature in actual med reconciliation when you're trying to figure out from multiple lists which med the patient's really taking? Okay. There's actually, do you think there's a role there? So we need to kind of think about it that way. And there may be, right? There may be a role for complete med history or reason for discontinuation, because if I see a pharmacy record, let's say I have 3 lists, a pharmacy list, and I have a physician's, orders, prescriptions, and let's say I also have the patient's statement that they're not taking this med. The pharmacy record doesn't usually say why it was discontinued. It just tells you that the last time they picked it up was a month ago. The prescription, the med history from the electronic medical record can tell you they're allergic. Okay. If so, the discontinuation may give you a clue as to which meds are active, right? Because you can look at meds and say, oh, here's a reason why this patient came off the med. So now if I have 3 lists, of which 2 of the lists say that the patient's still on the med, but I don't have any dispense dates, I'm going to assume they're not on it because I have one reason in one of those records that says they're allergic to it. So they most likely are not on it. So knowing whether the reason for discontinuation and if it was discontinued is actually pretty valuable in the med reconciliation workflow. It's also valuable when you're talking to the patient in the med management. Here's what I think you're taking, but it looks like you're allergic to this and you stopped taking it for that reason. Is that right? Okay. So that may fit in both of these categories. Okay. So this, so you see what we want to do is categorize these attributes that way, so that we always have a reason. We think we understand why, why we're actually, why we're actually justifying, why we think this type of a feature is important. Okay. Medication allergy history timelines, that's kind of related to number 2, right? It's basically you want to know the allergies to determine, if a patient should be continuing on a med or not. Is the allergy really important for med reconciliation when you're looking at meds side by side? You could argue either way. Generally, my feeling is that it's not, because your goal in this first step is just to basically do some accounting between different lists to find out which meds and which meds coming from each list represent a good picture of what the patient's probably taking. my guess is that, my feeling is that allergies probably are more important than the meds management side when you're trying to determine what a patient, when discussing it with a patient, what they should be continuing and what they shouldn't be continuing. Okay. Now, you could reason that it also belongs in med reconciliation, but we want to put reasons with each of these attributes now. So, or these features that we've identified. Okay. Um, then when we look at drug-drug interactions, so drug-drug interactions in a med reconciliation context of use in a workflow, it probably, it probably does play a role, right? And that's when you're looking at the whole final med list that you're coming up with, you're trying to also make sure that you don't have something silly like, I think the patient should be on an MAO inhibitor and phenylephrine or pseudoephedrine because, they both look like they belong in the same list. In reality, that, the patient should not be on these because of a bad interaction. So it may play a pretty important role in that, and definitely plays an important role in med management. Okay, so we may say that the med allergy, drug-drug interactions plays an important role in both. Is it more dominant in one than the other? Is it more important in one than the other? Uh, Probably not. I mean, I think it probably plays an important of a role in both scenarios. Okay. And so we want to rationalize again why it's important. Well, it's important here so that I don't come up with a silly, kind of med list at the end when in my reconciliation. I want to have some intelligence there and say these drugs in my final med list are potentially going to interact. Before I go and tell a patient they should take it, I should talk to the doc and make sure that they know that there's an MAO inhibitor because a psychiatrist ordered that, and you're trying to put them on a decongestant that actually is going to have an interaction with that. Okay, and they're important in this workflow because you're telling the patient what they should be compliant with, and you certainly don't want to tell them to be compliant with two drugs that interact. You want to talk to the doc here and reconcile that before you talk to the patient. And you may even tell the patient, hey, I talked to your doctor because I found some issues, and I want you to stop taking that Allegra D because I don't want you to, have an interaction with your MAO inhibitor. Okay. Counseling points. So, counseling points probably doesn't apply at all in MedRec, right? It applies more in the med management part of the workflow. And the reason is you don't have the patient in front of you here. You really have them in front of you after you've done your homework with different sources, right? So now you could argue that some of the workflow. You could argue that some of the workflows might require that you have all the med lists side by side, and you're talking to the patient to try to figure out which ones they're actually taking, and that's valid. But the actual hat you're wearing then is med management, because you've done your best effort to reconcile multiple lists of meds side by side, but then you'll have some meds you're not sure about. So really, when you're talking to the patient to see, to give them counseling points, you probably are already at the end point where you've created what you think is the active med list, and you want to give them counseling on how to take it, talk about adherence, and so it's probably more on this side than it is on the med reconciliation piece. Okay. And then if we look at the additional information required for inpatient, like home screening with the latest update on labs, okay, cultures and sensitivities, is that feature, which is, important data or evidence to show that a medication is effective, okay, or is going to be effective, is important during during the assessment phase of therapy, right? You're assessing, here are the current meds. What should they, are those meds appropriate? Okay, but med reconciliation process is really kind of reconciling multiple sources of meds, from different, from different systems. Is this important? I don't know. Is this important during that process of reconciling multiple meds? or is it process and med management, or is it really important in assessing the efficacy of the therapeutic intervention? Okay, I think that's a good question. That's something to think about. Okay, so I think that you could make a case for home screening and latest updates. Basically you're trying to find evidence that the drug is going to work or has worked, right? It's lowered my blood pressure. It's so for the home screening or latest updates on labs, my potassium is not going out of whack because I'm on a loop diuretic, or culture and sensitivity for to support that I should be on a ciprofloxacin when in reality my culture and sensitivity shows I'm resistant to it. Okay, so these are important pieces of evidence. Do you guys think it would be important in the med reconciliation context? What do you
No.
think? Yeah. It and we want to think kind of why it's this one's a tricky one. I'm not sure about this. I actually kind of think no too, but I'm doubting. And the reason is
Hi.
when you put lists side by side, okay, meds. Let's say that you have a med from Dr. A and a med from Dr. B, two different prescriptions. For Cipro and one for one for Cipro and one for Septra. Okay, and you have culture and sensitivity data, during the MedRec process. What would you do with that? You'd probably say, well, they look like they're on two antibiotics. Okay, one doctor has picked the right drug, the Septra, because probably because the culture and sensitivity show that that'll kill the bug. But and they also know that Cipro, it's resistant to Cipro. Okay, but so in the MedRec process, if you have drugs side by side, you might make a note that that the patient's on two antibiotics, or was on two antibiotics at different points in time, but they most likely are on the Septra because I have culture and sensitivity saying that the Cipro is obsolete. So maybe it's important in that respect of putting an annotation on the med to figure out, to ask the patient when you meet with them on med management, which drug are you really taking? Because we want you to take the Septra and not the Cipro. Okay, but you could also make the argument that for reconciling, lists against each other, that the cultures and sensitivity and observations don't really matter at this point. You're just trying to figure out from those lists what to prepare to talk to the patient. And it's really at that point when you're talking to the patient that you're going to suggest that they go with one drug over the other. Okay. Or it could be another part of the workflow. So what happens when you see that? When you see cultures and sensitivity data, and you have multiple sources of medications in front of you coming from different systems, what will you tend to pick up the phone and talk to the two different doctors and see if the guy that ordered the Cipro can discontinue it because you have culture and sensitivity saying that they're on Septra, and that Septra works? Kind of think about what you would do as a pharmacist, okay? And that'll determine in what point in the workflow this comes in. So when would you do that? If you have culture sensitivity and a med list, how would you use a culture sensitivity? What would you do? Yeah.
Go ahead.
I mean, I think that I would probably only I would probably use it during what you said, like the assessing phase, whether I don't think I would necessarily need it during the reconciling phase, but more looking at the medications and managing, maybe they shouldn't be on this one, maybe there should be a way to flag that they're on two different antibiotics, but I don't think that it's necessary for them to have the culture and sensitivity data right there on that screen.
Okay. Yep. Fair answer. Yep. Yeah. So I think, it's something, I would think about this one if you guys want to kind of toy with it and think, we only listed two workflows, med reconciliation, med management. are there any other workflows we might be missing? What do I do if I have multiple lists? I'll try to reconcile those lists in front of me. Maybe a subtask under reconciliation is evaluation of appropriateness of the final list before you talk to the patient, right? Because you want to do as a pharmacist, you want to attempt to assess, okay, I reconcile the list, and this is what it looks like the patient's taking, but then I also want to, as a pharmacist, decide what should the patient be taking, right? Because it could be that it shows they're taking simvastatin and lisinopril. Simvastatin and atorvastatin at the same time. That could be a fact. That could be that they are, on polypharmacy and taking two different drugs. So that's one piece of it. But then I also, as a pharmacist, do another task, right? After I do as part of my med reconciliation, I do basically, an assessment of efficacy and safety. So, and at that point, I look at observations, evidence, labs, so I look at blood pressures, blood sugars. I look at whatever clinical facts I need to tell me if this is effective, and I also and safe, including side effects, right? So maybe there's a sub workflow, which is basically assessment of efficacy, okay? And maybe then in that sub workflow, you do that. Or maybe we don't do this assessment of efficacy till we've done the initial reconciliation to figure out what they're actually actively taking right now. Because there's a difference between what we're observing in the list as to what the patient's actually, it looks like the patient's actually taking some of these meds incorrectly. It looks like they're taking polypharmacy. So it's good to know the current state of what they're taking. It's a different story coming up with an optimized, rational therapeutic regimen for their different conditions. Because then what you're doing is taking that raw list and saying, listen, they shouldn't be on 2 statins. They should only be on 1. I'm gonna address that issue with the doctor, and before you talk to the patient, because you don't want to go back to the patient and say, sure, continue on 2 statins. So kind of think in terms of the the workflow, and what additional steps would you do, and then where does this attribute live? So home screening, labs, sensitivities. Maybe that goes, as Nishtha was saying, kind of under this, And so, put it under here. Just put it there. Okay. Oops. Okay. And so what we want to do is build kind of a categorization of these of these features in that manner. Okay. And so what I'll do is I'll let you kind of think about that. Again, just think about it from a workflow perspective and how you would take these attributes and map them in there. Then as you start to think about the workflow, so I gather lists of meds from different sources. I then will try to reconcile them to what I think is a picture of what the patient's actually taking. And then I'll go through an assessment of efficacy to determine what they should be taking. And then after I get my act together and really know what I think I want to recommend to the patient, then I'll talk to them and do a med management type counseling, encounter. And so think about the workflows in that term, and then applying these features within those contexts. Okay. And that should, it should kind of start to paint a picture of why these attributes are useful, right? Because when you have them listed like that, we know that they're useful intuitively. We haven't rationalized them to ourselves as to what would I do with that data, right? Okay, what would I do with labs and blood sugars and cultures and sensitivities? Antibiotics, what would I do again with clinical data or observations about antibiotics? Stating that it's a part of my assessment of efficacy, it gives me a reason why it's important, right? Okay. And then entire history on antibiotics and failed and tried therapy. Well, that's a really critical piece, a really important thing. And it maybe again falls into this new category we just built, which is assessment of efficacy, because it's an assessment of efficacy, but it's also in the context of when is this important? Tried and failed therapy. It's important when you're assessing what a patient is currently getting, okay, and should they be continuing it or not. But it's also important in the feedback that you're giving to a clinician who just ordered yet one more time, Claritin for the patient's allergies. When failed efficacy, tried and failed therapy shows that they've been on Claritin for 3 months and it's never controlled their hay fever. Okay, so 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 that may be that may fall more into the assessment of efficacy, but it also may fall into the meds management workflow, because it gives you the patient may tell you, they may give you evidence that this never works for me, and so, but if you have that evidence supported by recent medical history that says they've been tried on Claritin and it failed several times, and the patient tells you it really doesn't work for me, then you've actually now verified and can make recommendations that they start on something else or just take them off Claritin. And change their regimen, optimize their regimen to be on, phenylhexidine. Okay, so think kind of in terms of putting reasons behind these attributes, and within the context of a med reconciliation, med management workflow. And as you're doing that, you're going to start to discover other features or attributes that would be helpful to you. Okay, and you'll start to kind of fill in the blanks on some of this. But I think that's kind of a good next step is rationalization of what you've identified with how you'd use it. Okay, and so if we just look at this list right now, there's one thing that's not on that list that might be very useful. Okay, can we think about it? We talked about why patients don't take meds, right? And you kind of hinted at it several places in here, but allergies or intolerances, right? So patients may not take meds for allergies and intolerances, but do we want to think about allergy reconciliation? It's we think we have in the med record that evidence of intolerances. Okay, what they can and can't take. Okay, but can we also, would that information be useful in med management scenario? In other words, is it useful to ask the patient, do you really get a cough with captopril? And they may say, no, I had a cough once because I had a sore throat, and I thought it was a captopril, but it's really my sore throat. Okay, so you can validate the intolerances, which will affect what regimen they actually should continue on. So maybe some level of allergy reconciliation is an important part of the workflow process for med management. Another thing that might be useful is where is it? The patient history. Do we have in here the patient's assertion of what they're taking? In other words, we have timelines and blocks, but we may want to detail that out a little bit more, and as far as adherence, and say what is the reported adherence versus the inferred adherence. So reported adherence is basically the patient telling you, here's my schedule. I take this 3 times a day, every day, pretty regularly. Okay. The inferred adherence would be the pharmacy dispense records showing that a drug supply that should have lasted them 30 days is lasting them 120 days, which means if it's lasting so long, then how can they possibly be taking it as routine scheduled as we think they are? Okay, they probably aren't. Or they could, the pharmacy data could be wrong. The pharmacy dispense data could be wrong. Well, why would the pharmacy data be wrong? They could be picking it up in different pharmacies, of which some of the pharmacies are paying cash, and therefore the electronic health record is wrong because it thinks that the patient only picked it up in 120-day intervals. But this patient goes there, has 2 homes. They have one in Connecticut and one in and one in Boston, and this actually happened with one of my patients, and so when they're in Connecticut, every other week they get it filled there. Well, and when they're in Boston, they get it filled in Boston. Well, the health record in Boston doesn't know about the Connecticut records, okay, and so basically they don't cross state lines, and so it looks like the patient's not adherent. Okay, so maybe we want to break this down into finer detail, observed adherence versus reported adherence, and and so there may be other things that come out of this, but for now, I think this is a really strong list. This is a very good list to start with. Okay. What I didn't see in here is some ideas on how to make it easier for the person doing reconciliation to do the reconciliation process. So we talked about the access to different types of data. Wouldn't it be useful to know if a med is is an order that's as needed, a PRN status, or a routine schedule? They're supposed to take it around the clock every day. Okay, so would that be useful to categorize the medications in terms of routine versus PRN versus one time? Would it also be useful to know the generic, to always have the generic name along with the med? So it's not always pharmacists that will do that reconciliation. It may be a nurse or a doctor. They may not know the generic, so is it always useful to have the generic name available? Is it also useful at all to group the meds, organize them, and present them in a way that's categorized? You already mentioned classes. Is now start to think how you'd use these things. Maybe I want to group the meds by classes or indications or the problems that they're taking, so that ideally they cluster together. I can deal with all the diabetes meds together. I can deal with all the hypertension meds together. So kind of I would think a little bit more about these types of attributes as well. How how you'd organize and how you'd sort and present the data to make it easier for someone to review it. So what would be really cool is if I was doing MedRec is I might even take an Excel sheet and design just an example of what a typical useful panel might look like. So if I were to do this, just to kind of open up an Excel sheet and I want you guys to kind of give this a try. Just go ahead and say if I were going to take a mock set, I might want to have the scheduled or routine meds, okay, routine meds, and as a grouping, and I might want to have PRN meds as a grouping, and I might want to also have one-time other types of meds where they're not PRN, they just got it one time, kind of as groupings. And maybe I want to then group by class or indication, okay? And then and then underneath that, I might want to group by generic. Okay, generic. And and when you group by generic, you might want to say, well, generic what? Like generic ingredient? So do I mean group by minoxidil? Okay, is a drug, so I want to just group by that minoxidil regardless of the brand name. And I have to really think about that and say, well, I don't want to really just group by minoxidil because minoxidil could be oral or a topical lotion. Okay, maybe I want to group by a generic with a route. So because I want the systemic drugs separated from the topical drugs. Okay, with generic with route. Okay, so then and that might be a good subgrouping, and then maybe then group by order with dispenses listed under in reverse chronological order. Okay, so meaning the most recent dispense on top and then count down, to older dispenses. And that way it's easier to quickly, look at the dispense history and see if there are gaps. So these are kind of, things that might be useful to then say, now let's experiment. Let's put some diabetes meds on here. Let's put some hypertension meds on here and see if that grouping makes sense. Would that make my life any easier? And then what if I, put these meds side by side so that they align by class, okay, and then they align by generic, okay, so that I can see side by side that, the meds that came from Boston Medical Center compared to the meds that came from Partners Health, are lined up side by side, so I can see what the differences are in dosing. Okay. So kind of, I would kind of do some prototyping, some experiments with Excel to see what you think would be very useful, and we could look at that, next week when we could have another call and just review and see what these look like, and that's when we start getting into kind of the design details, and we'll start to look at what the standards support, how we can actually do this using RxNorm and using the HL7 standards. Okay, so that's one thing that I think will be very useful to do, and maybe try to do some prototyping of what you think ideal med list options might look like in two contexts, right? We have two contexts that we were discussing. One context is I'm going to have a prototype, okay, that's going to be side by side panels from different sources, different hospitals, the pharmacy, and so on, that'll address my med reconciliation workflow. And then I'll have a final list which will address what I'm going to go over with a patient. It'll look like the same list, but what does a side by side list look like? Okay, how do you want to align it? So it'd be useful to. Yep. Mm-hmm.
So when you say a side-by-side list, are you saying when you're pulling each medication list and comparing them, or is like the computer taking the side-by-side lists?
I want to know, like you want to know, for example, let's show you here. Okay, we want the computer to present to us, what it has for different sources of meds, okay, coming from different systems. So for example, if I'm in Kaiser, okay, this might be the Kaiser list, okay, and then I might have actually been seen at Stanford, okay, so I might have,
okay.
yeah,
I see.
so you'll have like another. Let's make this red and.
So and then will you have like a final list that the computer is predicting what is likely, so that the pharmacist can kind of.
It should help you. The computer should help you get to that, and the pharmacist then needs to go through the reconciliation process of saying, hey, I know the computer suggested this, but I don't agree. I think the patient's on that. So for example, this might be Kaiser, this might be Alta Bates Hospital.
Okay. And then the way that you set those rows up in the Excel sheet, I'm assuming that each lower row is a subcategory, and it's like a hierarchy. That's your intention, to show a hierarchy tree, like in Explorer?
Yeah, with a little plus sign. You can imagine that if this is a computer, it might be a plus sign, and you can say, okay, grouped. So for example, I have routine meds, and under routine meds, I can have cardio or diabetes meds, DM drugs, okay, as a therapeutic class. And under DM drugs, okay, I might have in there insulin regular, okay, and then I might have under insulin regular, and it's 100 units per ml, Humulin, okay, so 100 units per ml, and that's Humulin, okay. So and then under that, I might have. And the order for that one might have been, on 5/1/2016, okay? And then I might have underneath that the dispense history. So I might have, 7/19/2017, and I might have, 5/19/2017. I might have another, which was 3/20/2017. So dispense histories of insulin, okay, And so you can imagine that it's kind of grouped in that way, all right? And this might have been Humulin, okay, and this R, and then this might have been some other generic brand, insulin R or Novulin R, or so you'll have basically dispense histories, okay, with quantities and so on. So you can see that what will happen is you'll have your routine drugs categorized as diabetes meds and hypertension meds and cardiovascular meds and so on. And so what you want to do, as you're organizing the list, is think about how you should organize a list that makes it most useful. And the reason that that perspective may be useful is that now if we look at the meds coming from different sources, okay, so let's say that let's say now we have Alta Bates, but we also have, besides Alta Bates Hospital, we have, let's pull up here, this is a different color, and then we have in here, Eden, okay, and then we have in here another source, which it's unlikely you're going to have more than 3 sources, but let's say this is a community practice, so this is Dr. Wilson Smith from Eden Practice, okay? So you have now, 3 different sources. If they all align, by therapeutic class, you won't be looking for insulin here, and then 50 rows down here there'll be insulin, and then maybe an insulin here, and then maybe an insulin here. They'll all be grouped together on the same line, so that you'll be able to see, looking across a section, you'll be able to see all the insulins, in this section. Okay, you may see all the antihypertensives in this section. Okay, and so you can see them side by side, but in this case, the instructions for insulin might have been 15 units in the morning and 30 units, or 30 units in the morning, 15 units in the evening. In this one, it might have been 10 units in the morning, 5 units in the evening. And so you'll have different doses, but as you're reconciling, you'll be able to say, oh, okay, the most recent doses were given with a higher dose insulin. These were really old doses, so they're not the ones that I want to, put down as potentially active. And and you'll be able to reconcile dosing all the way across the same row. So it makes sense?
Mhm.
Yeah. So kind of experiment with what you think would be useful to a user, because the alternative is to just have a non-sorted list of meds, that's in front of you, and then you as a pharmacist or a physician have to reconcile it. So you have to then, and it's a kind of a pain because then generics and brand names would, if nothing is sorted or grouped by generic, you'll have Zocor sort to the bottom, Simvastatin sort to the middle. You'll have, atorvastatin, sort to the top, but its brand is going to sort in the, in the middle. So you're going to have meds all over the place, and it's going to be really hard to reconcile them. So think about that type of a prototype or diagram, what you guys might think would be useful. And also think in terms, that's for the reconciliation workflow, but also think in terms, again, the backdrop for everything is a workflow. So think about your workflow for meds management. So meds management will be the outcome of you reconciling these lists, okay? And saying, okay, now I think I have a candidate single list for what I think the patient's on. What do I need, for the med management list? I would need to document how the patient is taking it versus how it was in the instructions, what the instructions said the patient's supposed to take. Or I need to know, I need a place to write down the side effects. I need a place to write down, reason for not taking it. So think of that's why the workflows are very useful, because as you design these screens, what will be helpful for a physician or a pharmacist or a nurse, it'll be largely driven by what you have to do with that list, right? So that's going to influence you. So if there are things that are on the med management side that don't matter to med reconciliation side, you don't want to clutter the med reconciliation screen with those additional fields that are going to be important for capturing,
I see.
counseling points and so on. So kind of think about it that way, but always think about it from the context of a workflow. Okay. Um, so if you guys want to kind of take a kind of take it to the next level, which is categorization of these attributes, and kind of starting to prototype examples in Excel of what these might look like. And think about patients who have multiple chronic conditions, diabetes, hypertension, maybe heart failure, maybe they have asthma, okay? And put together some of those types of, example medication lists and include the dates, the instructions, the provider, kind of the information you typically would see on a prescription or, on a patient history record. That'll be really useful, because then what we'll do is we'll look at these and optimize them. And so that's kind of, I think, the next step. But while doing that, if over the next week or so, you can also start to get familiar with, we want to now start talking about what exists in the real world. So as far as how this is represented in, in the electronic sources. So I would say to look at two things. To look at the RxNorm standard, okay, and you can Google RxNorm, but RxNav is a good way to look at it because that's a standard used in the United States to represent medication concepts. So Rx. So if you just kind of Google it, let's see, where's my Google? You'll find RxNorm, okay, and RxNav, and Anishta, have you ever heard of RxNorm? It's have you ever looked at it? Yeah.
I haven't really. I was Googling a little bit and I got a little bit confused.
Okay, well, that's okay. It's that's a good sign. So
if we don't have enough time, we can go over it with.
I think that'd be great.
Yeah, I can go over it with you another time, Roger. If you have a good grasp on it, we can try to.
I don't know if I have a good grasp, but I can tell you what. Yeah, we went over.
Okay, so the main thing about RxNorm that I think will be really important for you to kind of that's to start building your foundation of what exists in the standards today and national standards, and is to look at RxNav and just search for some drugs in there, because RxNav is basically a very systematic, nationally, adopted standard for just the medication concept, what the medication is. So if I look up in here, for example, Descovy. Okay, you'll see, and let me make it a little bit larger. And the reason you want to, kind of learn a little bit more about these structures is that these are how we're going to be able to represent medication classes and also link to medication indications. RxNorm, structures drugs, but it breaks them down very systematically. So if I was to look at Descovy, and let's pull that up, brand name. So so we have an antiretroviral regimen, and so it's a combination drug, okay. But you'll see that in RxNorm, it's basically a very standardized way of representing a medication. Instead of just a list of medications, it represents the definition of what's in that medication. It says it's composed of two drugs of different strengths of an oral, formulation of a tablet, okay. But it also breaks it down into the amounts of each drug, of each ingredient in the drug. It also then tells you what are the actual ingredients, the details. So it defines them. It says it's drugs in these amounts, and here are the standard ways of naming these drugs. There's two different ingredients, of which the little M means it's a multi-ingredient combination. It's not two different tablets. It's one tablet with two ingredients, okay? and it'll also tell you, what just at a general level how it's classified from a dose form group. So these are oral products. Okay, Descovy is really a combination oral product. Okay, and so RX norm kind of breaks down drugs into their ingredients, the amount of the ingredient, and the dose form of the ingredient. Now that's really useful because it allows us to take a brand name of Descovy, and regardless of if it came as multiple brands, they all are associated with the same generic drug. Okay, and so Descovy is only comes in one brand, but let's say that we look at Augmentin. Okay, let's look at Augmentin. I think there are multiple brands of Augmentin, right? Find out in a minute. Yeah.
You could do like insulin, glargine or something that has multiple brand names.
Yeah, that's a good one. Okay, so let's look at insulin glargine. Okay, so that's a good one. Okay, so here's insulin glargine. Okay, so you'll notice that if I that insulin glargine, if I just pick a single formulation, let's pick solution. Here we go. That's just Lantus. So let's find other ones. It actually injectable products. Okay, so if I wanted to look at generic names, for injectable, insulin glargine combinations, I can actually put one in focus. Okay, and it'll give me all the brands, all the different brands that it comes as. That up here. So insulin glargine, injectable products. Yeah. So here's insulin glargine, but it'll tell you for that generic, it comes as all these brands. Okay. So that means that we can, regardless of the brand, we can group them all together in the MedRec screen so that they aggregate together regardless of brand. So if at some point the patient got Basaglar and then another time they got Lantus, they wouldn't be sorted all over the med list. They would be all located in one area on the screen so that it's easier to do reconciliation against them. These kind of standards make what we are designing on the Excel a reality, so we can, we don't have to say, okay, well, how are we going to come up with all the generic and brand names for that? Are we going to have to do this manually or no? Because it can actually be done using the standards that exist today to translate these to common generic representations. And so it's good to learn about RX norm to understand how it's structured, and then starting to think about how we're going to apply the features of the standard to do what we want to in the Excel prototypes. Okay, so we get into some really interesting things, and this is just a drug name. Okay, this allows us to find out the class of the drug, the indication, the strength, the route, the generic. But we also want to show medication. We also want to know what are the ways of representing the instructions for the drug. What other standard data fields are available to be able to put on the screen for a user, like the date the drug was dispensed or the date the drug was prescribed. Okay, so there are several other data fields that are not part of RX norm because they're really more a part of the actual order that the patient had ordered, like the date and the dose. These are not attributes of the drug; it's attributes of the patient's order. Okay, and so we'll look at that standard the week after. But for now, to start in smaller steps, I think what I'd like to do is just make sure that we have a pretty good understanding of RX norm, and then so to do some exploratory kind of discovery of how drugs are represented in RX norm, and really understanding how they're broken down and defined. Okay, And then once once you have a chance to get a little familiar with that, then next week we'll go through complete walkthrough of how to use these attributes in ArcSnorm to do some really cool stuff with organizing med lists for reconciliation and for med management. So the reference for RxNorm, you can Google it, but you'll find a browser called RxNav, okay? And so if you use RxNav, it gives you kind of a visual this screen, which is kind of nice. You can actually search for drugs. You can actually pull up RxNorm and look at its different tabs that give you properties. These will look like Greek to you, but a good place to read about RxNorm itself is when you look at when you Google RxNorm, you'll see another reference. So let's look at here. I'm going to go RxNorm. And you'll see a reference. The first one that'll come up is an authoritative reference for RxNorm, which is the National Library of Medicine. Okay. And if you go to that, they'll have documentation that I will explain RxNorm, in much more detail. Okay. So there's an overview, which is useful, but there's also the detailed documentation that you can expand to that tells you what is a SAB, what is a TTY, why are those important? And so, if you could maybe review that, over next week, and we can, when we meet next, we can, I'm hoping maybe, if you guys are available, we can meet towards the end of next week, and we can go over, the details of RxNorm and what each of these, pieces mean. That'll be pretty useful, so that as a foundation for understanding how we're going to organize and present med reconciliation features. Yeah.
Hey, I guess I had one more question.
Sure.
I mean, this kind of relates to the medication reconciliation. And you had stated before, like, in optimal circumstances, like, if you could do anything. So are we at all thinking about, like, at the time when a med list, can be sent to a patient's phone, and then the patient has feedback back to the user about what they're actually taking or reason why they're going to stop, or, they're like, oh, I don't, because a lot of times we give a patient a medication list, but it's a physical copy. But I know there'll probably be a point where it's going to be an app, and then the patient will say, "Oh, I'm not going to take this," and it's like instant feedback. Is that into consideration of what we're going to think about in the med rec?
Yeah, definitely. That's fair game. Yep, that's definitely fair game. And ask me that question again next week, and we'll go through something called the ONC empowering patients access to their interoperable med list. It's a national initiative, and we'll go through that next week. But actually do list these things. These are all fair game, because when you do, then we'll start to look at what exists to support that today.
Okay.
Yep. Yeah, that's all fair game. Think completely out of the box on this.
Okay.
Yeah.
Sounds good.
Yeah.
So you said to try to meet towards the end of the week next week?
Yeah, and I'm thinking, because what I wanted to do is make sure that, I, kind of have a chance to see, you'll have some questions after you look at RxNorm standard and RxNorm itself. And also if you Google SureScripts, okay? So here's RxNorm, that tells you, that explains the standard for how medications are represented, okay? At least the drug piece of the medication, not the format of the order, okay? There's a difference because this is a medication concept. The standards for the order are basically what fields are necessary. Like a prescription must have a date, a physician, a patient name. The standards represent an order as well. That's not in RxNorm. That's actually in something called SureScripts, okay? And so if you kind of Google SureScripts, you'll find some information in here. And under SureScripts, you'll find that they use a national standard, and that one is called NCPDP. Okay, and we'll go over some of this, but just kind of do a little bit of reading, nothing in depth, just kind of get familiar with NCPDP and what it's about, SureScripts and what that's about, and also the CDA. Okay, and something called CCDA. Okay, and just you could look at usually the first thing that float up to the top are the national standards for those, and just do a little bit of reading about that. It'll get very technical, so don't get intimidated by the technology. Just read the overviews and to understand what they're for, and then we'll go through the details of that of the why these are important, because they're going to expose the data elements that we want to use in MedRec. Yeah. So again, nothing in depth, but just just get familiar with what look for the medication, where they address medication standards in each one of those references, and and that'll kind of start to give you an overview for those. A little bit of homework on those.
Okay.
Okay. Sounds good.
Great.
Yep.
And so while we're on the phone, should we try to figure out a time to meet next week?
Yeah.
Okay. And is this information, by the way, kind of useful? I'd like to get kind of feedback from you if it's not enough, or if you're getting stuck in certain areas, because we're going to start going into depth much faster. And I want you guys to just stop me and say, "Hey, Jim, let's go into more detail, something if it's not clear." Yeah.
So far, I've been okay.
Yeah.
Okay. Yeah.
It's
great.
good. Yeah. It's good.
So we'll ramp it up a little. Yeah. Oh, great. What does your week look like next week? Or maybe Thursday or Friday or Wednesday?
I'm pretty free any of those days, as long as it's kind of 12 to noon. If it's if it's Thursday, if it's Friday, I might be able to go a little bit over 1 o'clock. But if it's Thursday, I'll definitely have to cut it off, probably a little bit before 1.
Okay, so why don't we do this? Should we shoot for Thursday at 12?
That works.
That works.
Okay. So let's do this. MedRec. Next steps. Okay, so it's 12 to 1. And in the meantime, if you also want to try to do some, this Excel exercise of what you think would be, what would you need to see in the context of the two workflows we discussed, okay? And also to take the attributes that you've provided me and start to categorize them into, into these workflow contexts, kind of like what I was doing examples of on the screen. That will be really helpful so that we can look at that together, see what you guys come up with next week. Okay?
Okay.
Yeah.
Yep.
And so I'll send you an invite for this, and to
Perfect.
Roger and Nishta, and we'll put the same dial in. So here we go. Oops. And it's going to be the same join me too. So join.me/BSMI consulting. And I think we're set.
Thank you, Dr.
Sounds
Chavez.
good. Thank you.
And
yeah.
And then the recording is it?
Oh yeah. I'll send you a link to the recording. The recording, let's see, it takes a little bit of time for it to save. So let me just switch it here. Go down into recording. It's right here. And yeah, so I'll send you the link to it as soon as it finishes saving. So